Hello, I'm Morgan McCloud. I'm a second year PhD student at Duke University in biomedical engineering, and today I'm going to give a brief overview of my research, which covers robotic eye imaging systems. I want to start by asking you about the last time that you've been to an eye doctor, and to think about that experience. So, if you have been to one, you might recognize the device on the bottom left. This is the typical form factor of an ocular imaging system. These systems typically require a patient to be stabilized in a chin and forehead rest in front of the imaging device, and they also require a specially trained operator to align the imaging system to the patient's eye. This alignment and stabilization is required because the structures that we are trying to image in the eye are very small. For example, one imaging technique that's often used in the eye clinic is OCT, or optical coherence tomography. This is typically used to image the back of the eye, our retina, and the layers of the retina are only 100 or a few hundred microns thick. This is very small, 10 to the -6 meters in terms of scale. So it is very important that we are always aligning our system with the back of the eye very precisely so we can get a high quality image for good diagnostics. Another example of a commonly used imaging modality in the eye clinic is the slit lamp. These are often used to illuminate the front of the eye to see what's happening in the anterior segment. These can actually see blood cells that are floating around in the anterior segment, and those are also very small, only maybe 10 to 12 microns in size. So again, we need to make sure that our slit lamp is always very well aligned and focused to the eye, requiring stabilization and constant alignment with an operator. While this form factor is limiting, it can exclude patients that are mobility impaired and can't hold themselves still, even when placed in a chin and forehead rest. This form factor is also limiting to those that might be bedbound and can't physically place themselves in these systems. And this form factor, the tabletop imaging systems, are also harder to use in non-traditional eye care settings where a specially trained operator isn't always there to man the device. This begs the question, how do we get quality images of the eye without the operator and without stabilizing a patient? Well, our solution uses robots. This is because robots can carry instruments with very, very high precision and high repeatability. We actually attach an imaging system like an OCT or a slit lamp to the end of the robot and have the robot bring the imaging system to the patient rather than bringing the patient to the imaging system. Robots, unfortunately, don't come with eyes, so they don't necessarily know where to go. We therefore put cameras on and sometimes around the robot to give it context of the scene around it. When paired with the correct computer vision software, we can detect a person in front of the robot through face detection and eye detection. These pipelines will give us a tracking accuracy of down to 10 to 20 microns. So once we take the robot and pair it with an imaging system like OCT we have here, and then also connect it with the proper cameras, we can actually get the robot to approach and image a non-stabilized person. Here we can see the robot approaching, lock onto the eye, and we can see the layers of the retina being imaged with OCT. This can be demonstrated in actually multiple seating configurations. In the last one, this person was standing and now they're sitting. And similarly, we can see the layers of the retina being imaged with autonomous alignment. Here we actually attached a slit lamp to the end of the robot. And similarly, the robot will approach the person and then lock onto the eye, and a slit of light is shown onto the front of the cornea and imaged with some color cameras. And with that, I would like to thank my lab mates and my advisors for their support. I'd also like to thank the NIH, NSF, and Sloan Foundation for funding myself and my projects. And I'd like to give a very special thank you to my former advisor, the late Dr. Joseph Izat. And thank you for taking the time to watch.